This stuff's all over the exam, the 0500 to 0700.
Yeah. Okay. Just to repeat for people who are going to be watching the recording, we have a study group for the quiz on Wednesday at 4 p.m. It will not be recorded. So if you're coming, you're coming. If you're not, sorry. We're doing basic question answers. So we're not going over all the information. So there's no point for me to record it. So I hope that you guys can make it. Okay, we're going to start with chapter 30. If I can find it. Where is it? Sorry, it's not recognizing that I have them up. Where is it? Okay, there we go. Chapter 30. See it?
Yeah.
All right, perfect. Okay. Chapter 30, assessment and management of patient with vascular disorders and problems of peripheral circulation. Okay, the vascular system consists of two interdependent systems. We have the right side of the heart that pumps blood through the lungs to the pulmonary circulation, and the left side of the heart pumps blood to all other parts of the body through the systemic circulation. You have arteries and arterioles, capillaries, veins, and venules, and lymphatic vessels. Interrupt me when you need to, Adam.
Yeah, that's. I'll say someone keeps telling people, I don't know who it is, but someone keeps telling people that that's how you should remember heart failure is right side and left side. Left side pumps blood to the rest of the body. Left-sided heart failure is pulmonary congestion.
Yes.
So whoever's saying that is completely wrong.
Yeah.
So I don't know.
It's right side.
I know people keep telling me that, and I'm like, what?
No, it's right side.
It's
Right side
strange.
is pulmonary.
Yeah, it's just like the opposite for heart
Yeah.
failure.
That's the easiest way to do it. Just remember the right side goes to the lungs, left side goes to the rest of the body.
Yeah,
Because then you'll know when it says right or left side heart failure, you'll know what you're looking at.
the opposite. Yeah.
Alrighty. Functions of the vascular system. You have circulatory needs of tissues, blood flow, blood pressure, capillary filtration and reabsorption, hemodynamic resistance, and peripheral vascular regulating mechanisms.
It's whatever.
Yeah, pretty basic, just statements. Okay. Pathophysiology of the vascular system. We have pump failure, alterations in blood and lymphatic vessels, and circulatory insufficiencies of the extremities. And something to remember that we'll probably hit later, with the circulatory insufficiencies of the extremities, that's when you're going to see edema. So that's swelling in the legs. And that's because the fluid is not being removed because the circulation is not working properly.
It's all related to heart failure.
Yeah.
Decreased cardiac output, edema. Yeah.
Mm-hmm.
Big thing with this is like DVT.
Yeah, deep vein thrombosis, definitely.
DVT, PE.
And you have to be careful with the DVT because if it breaks off, you can end up having a clot in the lungs.
All right, so.
Still writing notes or ready to move on?
I'm good.
Okay. So this is just the systemic and the pulmonary circulation. So it shows left side and sorry, left side of the heart's in blue, right side of the heart's in red, and it shows you where it brings all of the blood. Okay. For older adults, we have aging that produces changes in the walls of the blood vessels that affects the transport of oxygen and nutrients to the tissues. Changes cause vessels to stiffen and result in increased peripheral resistance, impaired blood flow, and increased left ventricular workload. And when you have the increased left ventricular workload, that means that you're going to see that edema because the ventricular workload is what goes to the rest of your body. Any questions so far? Okay, we're gonna move on to the next slide. The assessment of the vascular system, you got health history, intermittent claudation, rest pain, which is when you have pain that goes away with rest. The location of the pain, your physical assessment, which is
Opposite.
what?
Pain that doesn't go away with the rest.
That doesn't go away with the rest. Sorry, you're right. For physical assessment, you got skin. You want to see cool, pale, pallor, rubber, loss of hair, brittle nails, dry or scaling skin, atrophy, and ulceration. And then you also need to check for the pulses.
Yeah, rubor is reddish blue color.
Yep.
On the leg.
And then when it comes to the loss of hair, the brittle nails, dry or scaling skin, the reason for that is because if you don't have adequate blood flow, then those things aren't going to be able to be produced properly. So you're not going to see hair where blood flow is not functioning properly. Okay. Assessing peripheral pulses. As we know, pulse behind the knee, on the top of the feet, by the ankle. All of these need to be checked when you're dealing with somebody who has especially left side heart failure or issues of the kind. Who can tell me what you do if you cannot feel a pulse? What do you use?
The Doppler ultrasound, if the
Yep.
pulse can be palpated.
Exactly. And it's important, especially for patients like this, that when you do find that pulse, mark it on their body with a little X with a marker or something. So that way, the next time you need to try and find it, you know where to look for it. Okay. Diagnostic evaluation, Doppler ultrasound, flow studies, an ankle brachial index, exercise testing, the duplex ultrasonography, the CT scans, the angiography and magnetic resonance angiography, so the MRA, contrast, phlebobiography or venography, and lymphoscintigraphy.
Lymphoscintigraphy.
Thank you. Oh, God.
I wrote stuff for these, but I only wrote stuff for the stuff that I didn't know about. So like, yeah, I'm not even gonna read it. But I wrote it for me, like, because I don't know. I didn't know what a duplex was and stuff.
Yeah. Okay, listed on here, we have a CT scan. What are the patient teachings for a CT scan?
Check for allergies.
Yep. What else?
They have to check like renal function.
Yep, renal function is important because they're going to be getting contrast. That's also why you ask for allergies.
And I think you have to watch for patients with diabetes.
Yeah.
I read that in the text.
Mm-hmm. And what are you going to tell the patient that they'll experience? What's it going to be like getting a What are they going to feel when they get the contrast?
Is it like warm and tingly, I think?
Yep, it's warm and you feel like you're going to pee yourself. And then when it comes to the CT scan, claustrophobia an issue? Yes or no? Whoops. The answer is no. A CT scan is very open. It's almost like a donut shape. So it's very open. You don't have to worry about claustrophobia there. Okay. The Doppler, we've seen pictures, we've seen videos of how the Doppler works, so I'm not going to go over that. Pretty much it's self-explanatory. Okay. PAD, peripheral arterial occlusive disease. Hallmark symptoms is intermittent claudation described as aching, cramping, or inducing fatigue or weakness. This occurs with some degree of exercise or activity. It gets relieved with rest. So it goes away when you stop exercising. Pain is associated with critical ischemia of the distal extremity and is described as persistent, aching, or boring rest pain. Ischemic rest pain is usually worse at night and often wakes the patient.
These are all resultants of atherosclerosis, arteriosclerosis, which are the same thing basically.
Mhm.
They happen at the same time.
Yep. Good to move on or still writing? This is an important slide, so I don't want to move on too quickly. Okay, we're going to move on. Pharmacological therapy for PAD. I'm not going to say all of them because I can't pronounce all of them, but aspirin, clopidogrel, which is Plavix, and statins. All of these are like blood thinners or antiplatelets. They're going to help prevent clotting.
So which one is antiplatelet? Which one is blood thinner?
Plavix.
Okay.
Clopidogrel is antiplatelet.
Aspirin as well.
Aspirin is also antiplatelet?
Yeah.
Okay.
Antiplatelet.
I always forget that it's not, I always mix aspirin up with the regular NSAIDs. Because it's also an NSAID, but it's not an anticoagulant, it's an antiplatelet. Okay. Nursing process, the care of patients with peripheral arterial insufficiency. Assessments. We're going to look at health history, medications, the risk factors, signs and symptoms of arterial insufficiency, claudation and rest pain, color changes, weak or absent pulses, and skin changes and skin breakdown.
Does the hypertension chapter mention that people usually need two antihypertensive agents or no?
I don't think so.
Because it says that here and I don't remember that.
I mean, I know that when it comes to like issues, when it comes to like heart failure and serious like heart problems, they want you to take two different
It
types.
says the majority of patients with hypertension require more than two antihypertensive agents to reach goal blood pressure. At
I
least
mean, yeah, it
one
depends on how
require
bad the
more.
hypertension is.
It just says majority.
Well, majority of people don't take care of themselves.
Yeah, so I don't know like if I should write this.
I would say that's more so for people with like severe cardiac problems. Because I know that
Because it makes
when
me
I
think
was,
that it's okay. Because when I see someone taking two hypertensive medications on like an exam,
Mhm.
I'm gonna think, oh, this person's on two hypertensive medications.
Yeah.
But then I would also see that maybe they're not if they're not hypotensive, it's fine. But because you would think someone would be hypotensive, but now that I'm reading this, I mean, you could tell if they're hypotensive in the question, but
well, yeah.
I'll probably just remember it and that's it.
Yeah. I mean, definitely remember it as like a fact, but I wouldn't remember it as like a definite.
Because I know people are on two of those, furosemide and something else. So furosemide and hydrochlorothiazide.
Well, furosemide is the diuretic, though. It's not a
Oh, antihypertensive.
hypertensive.
What should the anti?
It's not like an ACE inhibitor or a channel blocker.
Oh, it's,
Like they do the diuretics and the antihypertensives, but they're not the same, you know?
I know two are related to each other.
I mean, they do use the diuretics for people with heart problems, but it's not necessarily an antihypertensive med.
I think it's ACE and CCBs are used together.
Yes. If it's for heart failure, you have an ACE and a channel blocker usually.
Well, it's just this is majority. This is the wording.
Yeah.
It's confusing to me.
Mm-hmm.
'Cause I didn't think that was a thing.
Yeah, I mean, it just depends on what medication it is because they're all used for the same issue, but they're not all the same med. They don't do the same things, you know?
Oh, it says they talk about it. Okay, they talk, there's links to a thing. All right,
Okay.
whatever, I just don't remember.
Okay. Okay, diagnoses, altered peripheral tissue perfusion, chronic pain, risk for impaired skin integrity, and knowledge deficiency.
Poor perfusion.
What?
All of them are poor perfusion.
Yes, all of them are caused because of lack of oxygenation to the body. I got a 110 question for you guys. What diet do we put people on for impaired skin integrity?
I don't remember.
Protein.
Yeah, high protein. You were in that study group, so I was hoping you would know it. Yeah,
The
high protein.
chronic pain, does it specify like where?
Probably in the legs or arms where the edema is experienced.
Okay.
But yeah, high protein diet helps to prevent the degradation of skin, I suppose you could say.
The chronic pain is for heart failure related.
Yeah.
Most of this is heart failure related.
Well, yeah, but the heart failure leads to the edema, which leads to the
Right.
pain.
The heart failure is chronic though. So that's why it's chronic pain.
Yeah. I'm pretty sure all of this is chronic, the PAD.
Yeah, unless it, yeah, it's assuming no reperfusion therapy.
Yeah.
All this stuff is just bleeding into each other and it's really annoying.
Well, they're all very friggin' similar.
I know. So it's like you can kind of I skip so much now. Like
When you know the basic information, like the stuff that like is always there, it gets easy to remember.
yeah.
Like when
I
you
think-
remember like how the oxygenation affects the entire body, it's easy to remember the smaller things of all of the other little pieces. But if you have that main information about heart disease done, you're good.
That's called etiology, right? I think I'm all right with that. It's just like patient caring. I have to like
Patient care, yeah.
remember.
Yeah. I mean, especially when it comes to all of these heart issues, it's mostly medication based.
Yeah, because the disease process itself, I have a handle of it. It's just the patient care. I have to remember
Yeah.
all like the medication, especially like the side
Yeah.
effects and stuff.
Yeah, that's
Yeah.
why I was saying, yeah, I only do like med questions now because like the rest comes with it. Like it's not, yeah, it's not difficult to get the grasp of the like actual what they're reading.
Okay, nursing planning. Major goals include increased arterial blood supply, promotion of vasodilation, prevention of vascular compression, relief of pain, attainment or maintenance of tissue integrity, and adherence to self-care program. Okay.
So what medication will be used to increase arterial blood supply?
Adam, do you know this one?
Increased arterial, I'm thinking increased arterial blood supply.
Uh,
No. The first thing I think is vasodilation.
Yeah.
So I think nitroglycerin, but it says promote vasodilation.
Uh-huh.
What med is inotropic and quinotropic, like for the heart? Like increase the pumping, like the strength of pumping. There's two type of medication. One is increase the frequency, and the other one is increase the contraction strength
You're right.
of the heart.
I know what you're talking about.
Where's
I just
my list?
can't remember.
Well, you know, Dig slows.
I'm driving right now, so I can only ask questions.
You're always
instead of
driving.
looking for answer.
Oh, it's
Yeah,
digoxin.
Dig. Yeah. Dig is the one of them.
Digoxin improves the contractility and pumping ability of the heart. Digoxin.
Yeah, I said
Okay.
Dig is one. There's another one too.
Probably, yeah, but that's what I got.
Whatever. Yeah, it's
But digoxin is a friggin' drug that has 1,000,001 complications to go along with it.
But I think we can like learn the drugs, remember the drugs better this way, like by applying it to the
Yeah.
situation.
if I had like an infinite source of critical reasoning questions, that would be like exam based. I would like only do that right now.
ATI.
ATIs are right. I don't have access. She
They
just
should
won't-
really do that.
She won't give us the code, like, because anyone who wasn't here last semester,
Can't get on it.
or at least was in or was like, repeating. 110 people have it, I think.
Yeah, I think I can still log in. I haven't used it yet, but
Yeah, like we can't do anything.
I'm shocked that they haven't set that up. ATI is a great like practice quiz setting. And you can like make it exactly what you want it to be. Like I specified it when I did study groups last semester. Like I made it a specific quiz for what I was going over. Like even for drugs when I did my
wait.
studies for 115.
I got a thing that says your instructor has assigned you to a new cohort. You now have access to new resources. My results. What the hell is all this? Nursing 120 practice questions. Okay, I guess I have access now.
Oh, cool. Yeah, definitely ATI. They have great questions, I think.
Okay, yeah, I'm gonna me actually did something for me.
Hey, she likes you. That's why.
Yeah, I don't know if it's just me, but
Who knows?
hopefully not.
Okay. So we got improving peripheral arterial circulation, exercises and activities like walking, graded isometric exercises. And we want to note that consulting a primary healthcare provider before prescribing any exercise routines. We also have positioning strategies, temperature. It's affected by the heat and the cold. You need to stop smoking and to have stress reduction. Why did we stop smoking? What does smoking do?
Vasoconstriction.
Exactly.
Pretty much always bad.
What does the
What
cold
component?
do?
What does what do?
The cold?
The what?
The cold, the
Oh,
temperature.
cold.
Cold.
Same thing. I'm like, I think you said
It makes your nose runny.
Yeah, exactly. When you got it. Vasoconstriction, exactly. Why do we do positioning?
To avoid pressure spot. I don't know, pressure point.
To promote circulation.
Yeah.
So you're going to want to make sure that they're moving positions because certain positions have a better circulation to a certain part of your body than others do.
We only have 8 persons here today. 8 people.
Apparently. I know Alyssa's supposed to be coming later. I don't know when though. If she blows me off
By any
completely, she's
chance,
in trouble. What?
Megan, by any chance, did you guys go over the diabetes homework? Because I'm so confused of how she even came up with those questions.
We didn't go over it really. She kind of like showed it to us, but we didn't go over it. But I know that a lot of us are having issues with the wording of it. I can kind of go over it at the end if you want.
That would be great. Thank you so much, Megan.
Yeah, no problem.
I haven't touched it yet.
I haven't touched it either, but
Yeah,
I've
you don't
read
have. I'm
through
doing
it.
it tomorrow night.
Same.
'Cause they don't grade you on homework, so fuck it.
No.
You get it when you get it.
Oh,
just
yeah.
They
Busy,
don't.
man.
All our grades are all exam, right?
Yeah, I'm not busting my ass.
Dude, it's supposed to have been a vacation, and I have not had a vacation.
Oh, no,
Wednesday,
there's
I
no
prepared
there's no
for Thursday's
My
study group.
vacation starts after the second quiz is over, and I can just focus on the midterm.
Yeah. I don't know. Like
Oh.
Wednesday, I had to prepare for Thursday's study group. So, and then Friday, I got to like relax a little bit. But I also had friggin' clinicals like all morning. So like the nighttime I had to relax, but from like 8 a.m. until like 3 p.m. I was busy with clinical. And then Saturday was yesterday, I went apple picking with my fiance because that's what he wanted to do for his birthday. And I was in the hospital for his birthday. So we did it yesterday. But then I also had to prepare for study group today. And then on Tuesday, I have to prepare for study group on Wednesday. And then we have the quiz. I'm just like never ending, dude.
I just tell everyone I can't do anything.
Yeah.
I want to go. I want to go back to study, but I cannot. Like, I want to make a comment of like who would like to go apple picking for their birthday?
People like
Like-
apple picking a lot.
My fiance likes it because
Mostly,
he used to
mostly
do
a
it
girl
yearly
thing,
with his
but-
family when he was little. So
Oh,
it's a
there you go.
tradition that he wants to
Okay.
continue with our
I see.
family.
yeah, it's a big girl thing. I really like that. But
I
mean,
don't like it
I've
that
done that.
much.
I've gone apple picking just because someone wanted to go so many times, but like usually not guys, so that's a good thing.
I don't like it that much. It's okay, but my fiance did it every year with his family, and it's a tradition he wants to keep as we
It's
have
alright.
a family.
I like the vibe.
So-
I like the atmosphere of that. So-
Yeah. We went yesterday and it was 85 degrees though. I'm like, isn't this supposed to be a winter thing? Like a fall thing? Like I'm sweating.
Okay,
Okay.
what does stress reduction have things to do with the circulation?
Well, when you're stressed, doesn't your heart beat more? When you're stressed, doesn't your blood pressure go up?
So it helps.
When you reduce stress.
Yeah.
You don't want high blood pressure. You don't want a fast heartbeat, especially if their heart's
I
not
think he
functioning well in
means-
the
I
first
think he
place.
means like if blood isn't getting to areas, you would want your heart to beat more.
No, that just puts more stress on the heart. You
Yeah.
want less stress.
You would
Yeah,
have to
why
deal
would
with the underlying problem first. You'd have to deal with the area and make sure the area is okay and deal with any problem with the area, and then you can deal with the heart.
That's what I'm saying is like,
Yep.
because of the heart problem, so you want to reduce stress, not because to improve the circulation, you want to reduce stress. Yeah, okay. I looked at it the wrong way.
Yeah, other way. All right. Let's move on to the next slide. Okay, so we have arterial disorders. We have atherosclerosis and atherosclerosis.
Arteriosclerosis and
Thank you. Arteriosclerosis and atherosclerosis. Peripheral arterial occlusive disorder, disease, upper extremity arterial occlusive disease, aortoiliac.
aortoiliac.
Thank you. Or aortoiliac disease, aneurysms, thoracic abdominal other, dissecting aorta, which is when it literally just like splits off of the heart. It's bad. Arterial embolism and arterial thrombosis, and Raynaud's phenomenon and other acro syndromes. I have a feeling you have stuff to say about this one, Adam.
It goes over them individually.
Oh,
I
it
can
does?
do arteriosclerosis and atherosclerosis if you want. Because these slides are like weird. They're like not in order of the chapter.
They're not? Of course not.
Because like yeah, arterial disorder. Oh, I guess it is, but it just explained basically arteriosclerosis and atherosclerosis before we even went into it.
Yeah,
That's the intermittent claudication is symptom of generalized atherosclerosis. Like,
I'll just go through it slide by slide because that's how it's broken down and you can add as you need.
yeah.
Okay. Sounds good.
Wait, does it even like, let's see.
It breaks it down pretty well.
Okay.
Okay. So let it move on. Okay, arteriosclerosis and atherosclerosis. Arteriosclerosis is a hardening of the arteries, diffuse process whereby the muscle fibers and the endothelia lining of the walls of small arteries and arterioles become thickened. Then you have atherosclerosis. It's different process affecting the intima of large and medium-sized arteries. It's accumulation of lipids, calcium, blood components, carbohydrates, and fibrous tissue on the intimal layer of the artery, and atheromas or plaques.
Same atherosclerosis that we did already.
Yes.
So these happen at the same time. Stiffening happens when there's
The buildup.
a thinning of when there's a thickening of the wall because it has to work harder anyway.
Yep.
To get blood through. So these both are interchangeable. They happen at the same time. So
They're
you will-
different, but they happen together.
Yeah, the book also says that the names are interchangeable because they happen at
Okay.
the same time almost always.
Okay.
So
Yeah,
it can
but-
be like atherosclerosis, arteriosclerosis, the other one is present.
Okay.
But Harrison asked us to differentiate them when she talked about it.
Yeah,
don't
one
know
is
why.
it's like one is the outer and one's the inner.
Okay.
Yeah, the outer wall thickens and then the inner wall narrows, which is athero. But like in a person, at least the book doesn't go over like a way where you would, it just merges them.
Yep. Thank you.
The same stuff goes with atherosclerosis as we did. So like
Yeah.
serum cholesterol is monitored, atorvastatin,
Mhm.
it's fat, it's lipids. Yeah.
Yep.
And then it causes arteriosclerosis. So same process.
So
It all connects.
arteriosclerosis doesn't have the lipid, calcium, and blood
No.
component accumulation.
No, because
No,
it's the
a
outside.
result of it. Yeah, it's the
Okay.
walls. So because the inside has all the fat, lipids, and everything, narrowing the vessel, it has to work harder for the blood to like get through, which thickens and makes the vessel thicken.
Okay.
Alrighty, moving on. This is just a visual of the progression of it. So you have the clear, and then it slowly has the fat streaks, then the fibrous plaque, and then we have the thrombus. And it's a complete hemorrhage, ulceration, calcification, thrombus. And that's when you're going to see myocardial infarction, stroke, or gangrene, which is the dying off of an extremity.
and it becomes black.
Yep. It's gross,
It's on some of the dummies in the skills line.
right? Okay, and then this is common sites of the atherosclerosis obstructions. In the box, it shows the popliteal. That is where you will most likely find deep vein thrombosis. Okay. Risk factors for atherosclerosis and PVD. The modifiable kinds is nicotine and diet, hypertension, diabetes, obesity, stress, a sedentary lifestyle, C-reactive proteins, and hyperhomocysteemia. Non-modifiables are age, gender, and family predisposition and genetics.
I was wondering why it didn't go over prevention. It might in the next slide. I don't remember.
No, it
but
doesn't. Next slide is a question.
yeah.
I
realize
mean,
it's all
this is
stuff.
kind of prevention too.
It's all just hypertension is obviously something that would cause this. You deal with the underlying. You
Yeah.
always deal with an underlying, so it's not even like something you even have to think about.
Yeah.
It's just the way this garbage is worded is like.
Mm-hmm. But yeah, I mean, when you think about it, you have the modifiables. That's the ways to do preventative.
All of these are the same modifiables as hypertension, every single one.
Yeah.
Obviously, hypertension would be a thing you want to prevent.
Hypertension leads to this, does it not?
Yeah, at least atherosclerotic lesions. Yeah.
Exactly. So control the hypertension and all the things that cause hypertension, and then you're good to go.
Yeah, and even says, although no single factor has been identified as the primary contributor to the development of atherosclerotic cardiovascular disease,
Mhm.
greater number of risk factors, the greater risk. And no shit. Okay.
Yeah, no shit.
This is the area I was going over again. I stopped at clinical manifestations.
Yeah.
Oh, yeah. I mean, if you want to add to it, it's not going to mention it because it preceded this, but intermittent claudication is a symptom of generalized atherosclerosis.
Mhm.
So it's a big thing.
Yep.
It's just misordered in the slides, but it's in the chapter.
Yeah. Okay, question. The nurse is staging a patient diagnosed with peripheral arterial disease or PAD. What should it include in the teaching plan? Elevate the lower extremities, exercise is discouraged, keep the lower extremities in a neutral or dependent position. Whoops.
Oh, shit, I didn't see it actually.
And then PAD should not cause pain. So what are you teaching your patient?
Neutral position.
Yep. Neutral positioning. Blood flow to the lower extremities needs to be enhanced. Therefore, the nurse encourages keeping the lower extremities in a neutral or dependent position. In contrast, for patients with venous insufficiency, blood return to the heart needs to be enhanced, so lower extremities are elevated. Exercise can be prescribed to aid in the development of collateral circulation. Some pain is associated with PAD. Aneurysm.
Legs hanging off the bed.
Yeah.
Mentioned a lot.
Okay, localized.
PAD cause loss of hair on the extremity, right?
Yep.
Okay.
Okay. Localized sac or dilation formed at a weak point in the wall of the artery, classified by its shape or form. Most common forms of aneurysms are saccular and fusiform. Saccular aneurysms projects from only one side of the vessel. When entire arterial segments become dilated, fusiform aneurysm develops. And we're going to see what they look like next.
Yeah, people get confused where they see aneurysm and they think like
Great.
it's a blockage and then it can pop.
Mhm.
So it's first a blockage and then it can pop, and that's where the hemorrhage comes from.
Yep, there's a difference between the aneurysm and the hemorrhage. Where are you going, Bun?
Yeah,
Where are you going?
going to Pennsylvania,
Oh, wow.
What are you doing in Pennsylvania?
picking up an Xbox and then flip it. Because I'm using program to like buy system and then sell it.
Nice.
Cool. Alrighty. So these are what the arterial aneurysms look like. This is the repair of the ascending aortic aneurysm. So it just shows you how they repair it, which we don't really need to know because we're not the ones doing it.
Yeah, the brain one is, I think, a thrombolytic. But
I have no idea.
yeah, you can't open the brain.
Yeah, exactly.
Well, you can, but you can't open.
Yeah. Okay, Raynaud's disease. Intermittent arterial vaso-occlusion, usually of the fingertips or toes. Raynaud's phenomenon is associated with other underlying disease such as scleroderma. Manifestations: sudden vasoconstriction results in color change, numbness, tingling, and burning pain. Episodes are usually brought on by a trigger such as cold or stress. It occurs most frequently in young women and protects from cold and other triggers. Avoid injury to hands and fingers.
This is what happens in kids, right? When you give them a medication.
Yeah. What med is that?
Is it aspirin? No, there's baby aspirin.
What is it?
It's one of those. It's like
Yeah.
really.
I think it's an NSAID, isn't it?
I have it on a card, like a recent one. If it's ibuprofen or acetaminophen,
Let me look.
probably.
Do we have a risk factor slides for this one?
Risk factor slides? I don't think so.
Okay.
We have
I wanna know
preventative
what-
measures. Oh no,
I
not
want to know
Raynaud's syndrome.
what causes it.
Oh, it's Reyes
Oh,
syndrome.
Reyes syndrome, and this is disease/phenomenon.
It's
That's
different.
bullshit. Whatever. They should
It's a
just
different disease, Adam.
Yeah, I think this is in everybody, and the other one's just in kids. Yeah, you're right though.
Yeah, it's aspirin. It's
I knew
black
it was
box.
one of
Do not
those
give to
things.
children with chickenpox or the flu. Risk of Reyes syndrome. But it's not this.
I had that on an exam, so I can't forget it.
Yeah. Do not forget that. Thank you, Tony. You're right. Alrighty. So venous disorders, we have venous thromboembolism, chronic venous insufficiency or post-thrombotic syndrome, leg ulcers, and varicose veins. Okay. Venous thromboembolism, it's a pathophysiology, risk factors, endothelial damage, which is venous stasis and altered coagulation. Manifestations is deep veins and superficial veins. Okay, we're going to talk about preventative measures. The application of graduated compression stockings, pneumatic compression devices, early ambulation, subcutaneous heparin or low molecular weight heparin, and then lifestyle changes such as weight loss, smoking cessation, and regular exercise. How do the compression stockings work? What do they do? You have
I
somebody
never
in the,
saw it in person.
okay,
I have the idea of it,
yeah,
but
okay.
never saw it in person.
So I'll lay it out for you. You have somebody who just came out of surgery. And what you do is you have these things and you wrap them and Velcro them around their, it goes pretty much from their knee to their ankle. And they squeeze, they inflate with air, and then they deflate every few minutes. They do that. And it's a compression device. Why do we use those? How does it work? What does it do?
Sequential compression of the vein to promote circulation.
Yep, it promotes circulation and it helps get the blood that's in the legs back up to the heart, and that prevents blood clots.
So did they put it on as like a blood pressure cuff?
It's similar, but they stay on. But it is similar to a blood pressure cuff. It does inflate like one. Probably not as tight. Not as tight though.
What is early ambulation?
I believe it just means that you start doing
Post-op.
ambulation.
Yeah, post-op, you want them to get out of bed as quickly
Yeah.
as possible, early ambulation.
Exactly.
Okay.
Or, early ambulation, because this is post-op is when you would get a lot of these clots. So
Yep.
we're even on a post-op unit, but
Nope.
yeah, that's where all these things are. And yeah,
I mean, you will see them on the floor when it comes to the compression devices and the compression stockings.
and the
Those
post-op
you'll see
floor
on
that we're
floor.
they're all, it's every patient. Every
Every
post-op
patient,
has
yeah.
them. And the early ambulation is a thing for post-op, or even someone who's admitted to the hospital, you still want early ambulation.
Early ambulation is for every single post-op patient. As soon as they can, you get them up and walking, because the sooner they're moving, the quicker they heal. The more time you have patients in bed, the worse they're going to be. Unless they have to be on bed rest for whatever they're there for. But you want to have your patients walking, because if they're not, then they're not getting proper blood flow. They're not getting proper oxygenation, because shit's going to sit in their lungs because they're not moving enough. So you need to make sure that you have your patients walking always. And they're not going to want to, especially post-op. Post-op is not going to want to walk, but you got to make them. Because they're in pain from their surgery, but walking is going to be the best way for them to heal quickly. Okay. Question. Which patient is at the highest risk for venous thromboembolism? You have a 50-year-old post-operative patient, a 25-year-old patient with a central venous catheter in place to treat sepsemia, a 71-year-old otherwise healthy older adult, and a pregnant 30-year-old woman due in 2 weeks.
A good question.
Yep. Fun, I know you know the answer because we did it in class. Don't answer.
I'm not going to.
This is for anybody in Me's class.
I think they would do it as well, no?
No.
They just skip everything.
Yeah. As far as I'm concerned.
Yeah, they skipped it.
Okay, we got somebody who said A.
Yeah.
A.
You know what? So this study group is more beneficial to whoever is in these class, because
That's
it's like having 2 lectures.
fun. That's why I do this, because they don't learn anything. That's why I do this. Okay, we're gonna go through this step by step because unfortunately A is not the correct answer. So, patient A, 50-year-old post-op patient. Well, how many risk factors do they have? 50 is not an older adult, 65 is that mark. So 50 is a fine age and they're post-op, so they have one risk factor. A 25-year-old patient with a central venous catheter in place to treat septicemia. Well, 25 is a young age, which is great, but the venous catheter is one risk and he's being treated for sepsemia. So that's two risks. Moving on to C, you have a 71-year-old, otherwise healthy. 71 is old enough, but they're healthy. So that's one risk. And then a pregnant 30-year-old woman due in 2 weeks, pregnancy is one risk. So B has two risks, the others only have one risk. So B is the answer. Does that make sense for everybody? Okay, cool. Okay, so we got varicose veins, prevention, avoid activities that cause venous stasis, wearing socks that are too tight at the top or that leave marks on the skin, crossing the legs at the thighs, and sitting or standing for long periods. You want to elevate the legs 3 to 6 inches higher than heart level. Encourage to walk 30 minutes each day if there are no contraindications. Wear graduated compression stockings. And overweight patients should be encouraged to begin weight reduction plans.
Oh, I have a question. Then why would they put compression socks on the patient? I remember, I think I put on the socks with you for the patient before, Megan, right? It's hard to put it on.
Yeah, they're very tight.
Too tight.
It's almost similar to the sequentials that you put on that squeeze after surgery. It kind of just helps the blood flow go back up to the heart.
But when you read here, like I wish you avoid putting a tight socks, which leaves marking on the patient.
Yes, they're different types. Because like you have ones that are, when you're wearing socks, normally they're lower on your leg. They're not all the way up to your knee. And they are tighter where the elastic is compared to where the rest of the sock is. When it comes to the compression stockings, it compresses the entire leg from knee down. So it kind of is like squeezing the entirety of your lower, from your knee to your toes is all being squeezed. So it pushes it back up. It doesn't just cut it off at one spot.
It doesn't go down as well if it's too tight.
Well, no, because the body is able to do, with gravity's help, it goes down easy. Getting back up is the difficult part.
Okay, for now.
Okay, for now. What do you want from me, Bun? That's what they do.
The answer doesn't satisfy me, but
Okay, well, I'm sorry, but that's just the answer. They're compression stockings. They squeeze to help blood go back up to the heart. That's what they do. I don't know what you want from me.
okay.
I'm not an actual teacher. I don't know all the answers.
I
Don't forget I'm learning this the same time you are,
It's
dude.
an open discussion, that's why.
Yeah. We can disagree as much as we want, but facts are facts, bro. Okay. So nursing process, the care of a patient with leg ulcer assessment, history of the condition, assessing pain, peripheral pulses, and edema. Treatment depends on the type of ulcer. You want to assess for presence of infection and assess nutrition.
What nutrition we're talking about here? Still
Well,
high protein.
Yeah, if we're talking about the outside, when we're talking about ulcers, it would be high protein to help with skin.
Okay.
Okay. Medical management, anti-infective therapy depends on the infecting agent. Normally oral antibiotics are used. You have compression therapy, you have the debridement of the wound, you have dressings, and then there are others. Alrighty, next we have the diagnoses. So these are the nursing diagnoses that we do on the care plans. Some examples for this is impaired skin integrity related to vascular insufficiency, impaired physical mobility related to activity restrictions of the therapeutic regimen and pain, or imbalanced nutrition, which is less than body requirements related to increased need for nutrients that promote wound healing. That would be your high protein diet. Collaborative problems and potential complications are infection and gangrene. Gangrene is pretty much the decomposition of tissue. So it's pretty much like dying. So you'll see it in toes, you'll see it in feet, you'll see it in fingers, mostly the extremities. It's where you're not getting enough blood and the cells die, which leads to the death of those extremities, and usually it ends with amputation. Okay. Interventions restore skin integrity, improve physical mobility, promoting adequate nutrition, and promoting home and community-based care. So these are your nursing interventions. So it goes hand in hand with whatever your nursing diagnosis was. Restoring skin integrity, we're going to be cleansing wounds, positioning, avoiding trauma, and avoiding heat sources.
How does avoiding heat sources help?
Well, skin degrades easily with heat. Also, heat can cause trauma. Think about it, when you're out in the sun, what does it do to your skin?
But in that case, they will include cold as well. Because
Well,
cold can damage your skin.
cold doesn't damage this. Well, yes, it can damage the skin if it gets to a low enough temperature. But you're more likely to experience trauma when it comes to heat. And also, like, think about when you're in the sun too long, it damages your skin.
Is it also because it dries out the skin?
That too.
It has to keep moist, right?
Yeah,
Oh,
it absorbs, it takes away the moisture in the skin, which helps it degrade faster. Improving physical mobility. With leg ulcers, activity is usually initially restricted to promote healing. You gradually progressive activity. Activities to promote blood flow. Encourage patient to move about in bed and exercise upper extremities. Diversional activities and pain medication before activities. So if you have a patient who has physical therapy coming to help them do some exercises, you're going to give them their pain medication before they show up, depending on what pain medication they're getting, maybe like a half an hour early if it's oral, and that will help them do better with their exercises because they're not in as much pain. Okay. Promoting adequate nutrition. We want protein, we want vitamin C and A, iron, zinc, and then many patients with peripheral vascular disease are older adults. Particular consideration should be given to their iron intake because many older people are anemic. Making sure they're treated for anemia is important because the anemia messes with the red blood cells' ability to transfer nutrition and oxygen to the body. So that's very important to make sure that's being handled properly. And the outcomes that we expect from all of these is to demonstrate restored skin integrity, increased physical mobility, and attains adequate nutrition. So that's the outcomes that we expect to see when we do all of these different interventions. And the last two things we're going to touch on for this chapter, lymphatic disorders. Lymphangitis is the inflammation or infection of the lymphatic channels. Lymphadenitis is the inflammation or infection of the lymph nodes. And then lymphedema is the tissue swelling related to obstruction of the lymphatic flow. Primary is congenital, secondary is acquired obstruction. Okay, and the last thing we're gonna do is cellulitis.
Can I have ultimate?
Fun.
Yeah, a supreme. Yes.
Okay, sorry. Okay, signs and symptoms of cellulitis is localized swelling or redness, fever, chills, sweating. You treat with oral or IV antibiotics based on the severity. And then for the nursing, you elevate the affected areas. Warm, moist packs to site every 2 or 4 hours. You educate regarding prevention of reoccurrence, and you reinforce education about skin and foot care.
Help me understand something really quick.
Yeah.
Um, peripheral arterial disease is just atherosclerosis in lower extremities.
Yeah.
So atherosclerosis that affects, so you have, so PVD, PAD, it's all just like different, you know, extremities.
Yeah, pretty much.
Okay.
It gets confusing. Okay, that was the last slide for chapter 30. So we are halfway done. I don't
There's
think
really,
chapter 31 is not as long.
it's very short.
Yeah.
There's
So
really
that's-
good QSAN alerts in this chapter that we just did.
What is it?
The quality and safety nursing alert things, but they're actually relevant this time.
Okay.
Where it says, because I said I'm going over it slowly, so for like atherosclerosis, it says, you know, you're supposed to avoid extreme temperatures.
Mhm.
It says patients are instructed to test the temperature of bath water and avoid using hot water bottles and heating pads.
Yeah, we were saying you have to avoid heat.
But it gives like specific, you know,
Yeah, examples.
may increase the metabolic rate. Yeah.
Mhm.
Use with a great caution in general. Okay, because it mentions weather, and I'm like, I wrote weather, but I should write other things.
Mm-hmm. Alrighty, let's move
This is
on.
It's like 1 page.
You can see this, yes?
No, now I can.
Okay. I'm like, you can't see it?
It was black for me.
Yeah, okay, cool. All right, chapter 31, assessment and management of patients with hypertension, high blood pressure. Okay, hypertension, high blood pressure, most common chronic disease among US adults. Hypertension is defined by the American Society of Hypertension and the International Society of Hypertension as a systolic blood pressure of 140 or higher, or a diastolic blood pressure of 90 or higher, based on the average of 2 or more accurate blood pressure measurements taken 1 to 4 weeks apart by a healthcare provider.
That's important.
Very important. You cannot diagnose somebody with hypertension unless you are taking and monitoring their blood pressure over a long period of time. Just because somebody has one high blood pressure doesn't mean they automatically have hypertension. Okay. So classification of blood pressures for adults age 18 and older. So we have the normal levels, the pre-hypertension levels, stage 1 hypertension and stage 2 hypertension. Yeah, there are some
Normal
number variations.
tension. Yeah, just focus. Don't worry about it. Well,
They're
stage
not,
two,
these aren't set in stone, but these are about where you are looking for.
you don't need pre-hypertension. Normal is
Yeah.
normal. Hyper stage 1 is like minimal, and stage 2 is just severe, like, you know, it's just severe hypertension.
Yeah.
And with the effects that come with that.
Mhm. Okay. Incident of hypertension, the silent killer. Primary hypertension is essential. 95% of patients have this, and it's an unidentifiable cause. Secondary hypertension is in 5% of patients, and it's because of renal disease, sleep apnea, and pregnancy. About 33% of adult population of the US has hypertension. About 46 do not have it under control. And the highest prevalence is in African Americans. So this is a really, really big deal that almost 50% do not have it under control, because hypertension needs to be controlled, because if it's not, it can lead to damage of other organs. And that's the thing, is that with hypertension, you don't really have any indicators saying, hey, you have high blood pressure. Like, there is not any big, yes, it leads to the increased workload on the heart. Yep. And so with this increased pressure of the blood, it's going to slowly deteriorate your other organs. And a lot of people find out that they have high blood pressure because they have organ failure issues, or to a lighter extent are having issues with other organs. So if you don't keep this under control, this becomes deadly very easily. And because it doesn't have any real symptoms, it's something where you need to go to your doctors and get your blood pressure checked and make sure that you are treating it properly and managing it properly. Okay. Factors involved in the control of blood pressure. So you have things like excess sodium, stress, obesity, endothelium factors, genetic alterations, and fewer nephrons.
What nephrons?
Aren't they the cells in your brain?
The kidney
Kidney?
No, kidney.
Kidney.
I
function.
didn't hear the term that you used.
I have that in my head, like mitochondria is the powerhouse of the cell. That's like how I know nephrons.
Kidneys.
Being part of the kidney.
Yeah. Okay. So we got manifestations of hypertension. Like I said, usually no symptoms other than the elevated blood pressure. So symptoms related to organ damage are seen late and are serious. You have renal and other eye changes, retinal and other eye changes, renal damage, myocardial infarction, cardiac hypertrophy, and strokes. So these are when some people find out they have hypertension because they don't go to the doctor, they don't get things checked out, and they get so bad that eventually they end up having a heart attack or having renal damage or a stroke.
I think it's usually like really bad headaches and like eye pain are like the presenting thing. I don't know if it says it, but you know, high blood pressure, headache, eye pain.
Yeah. Usually the first thing you'll have is the retinal and eye changes.
Next time I have a headache, I should measure my blood pressure.
Yeah, like no, for real. Yeah.
Yeah.
Yeah, people who have like headaches all the time usually have like chronic, you know.
Yeah, recently I don't, but I used to have a lot of headache, like almost once a week.
Yeah.
Oh,
Recently,
dude, I get
don't.
headaches like almost every day, but I also have issues with migraines. So
Have you measured your blood pressure when you have migraines? Like,
No.
I never.
I've never measured my blood pressure when I have a migraine, no. But usually my
Right.
blood pressure is low, so
See if it elevates. I want to find out, not just you.
I
Like,
don't know.
I want to find out myself.
It's normally
Yeah.
low, by the way, and maybe your blood pressure is normally low, but then it rises to like 120/80, which is abnormal for you. It's high for you.
Yeah.
You get a headache.
It's probably. I mean, I know that on a normal basis, like when I'm in the hospital and they come and take my blood pressure when I've been like sleeping or laying down or just doing whatever, it's on the lower side. But I know that when I go into the hospital and I'm having a lot of pain, and that's when it's like normal or a little elevated because of the pain. So it's very likely that if I have a migraine, it's also elevated because pain does that.
It's whatever low, because blood pressure is dumb. It's like in reality, it's like everyone has a different normal.
Yeah.
And in the book, you have to go by what the book says. But in reality, people have all different normals. 120/80 isn't like, you know, might not be what someone's blood pressure.
The biggest thing that you'll end up asking people is, what is your normal blood pressure? Are you normally a low blood pressure? Are you normally a high blood pressure? Stuff like that. As it is
don't
the
think
same
they
with
would
heart
know.
rate. Some people don't, but some people do. I mean, when they ask me in the hospital, they're like, "Do you normally have a low blood pressure?" I'm like, "Yeah."
Older people
Yeah.
also know, a lot.
Yeah.
I don't think like majority of people will know the numbers. Like
Oh,
they
they
would just say
They'll know-
low or high.
Yeah,
They don't know
If-
their exact numbers, but they'll know if they're normally low or high.
yeah. We have people in our, and even on our unit in the hospital right now who they all know, like, but they're
Yeah.
some of them are older, whatever.
Well, that's the thing is that a
But
lot of your patients, if you're just working on a normal med surge, a lot of your patients are going to be older and they are going to the doctors all the time or in the hospital and they know that stuff.
Okay.
You'll have
Yeah.
patients like you'll see we were talking about in clinical patients with COPD. They know what their blood ox usually is, so they can tell you that's normal for me. Patients who have illnesses, they're usually going to be chronic illness patients, or at least go to the doctors all the time because of their illness. They'll have an idea for the most part. You'll have the odd like 25-year-old who has no idea, but other than that, they usually have an idea.
yeah, most of them are also hypertensive.
Yeah, true. Like we said, it's a very high percentage of the population with hypertension.
If you're hypertensive though, your norm is actually like if you have like chronic hypertension, like you cannot make the lifestyle changes because you have things that are making it to.
Yeah, well, you have things like genetics and stuff that play a part.
You can also yeah, genetics is a big thing. Your norm becomes that high.
Yeah,
Mm,
but that doesn't mean that it's safe though.
No, it's just what your normal is.
Yeah, if you're normally high, it still needs to get lowered to a safe rate. But it doesn't, like, that just means you deal with severe hypertension.
Yeah.
When it comes to having low heart rate, that's something where depending on how low it is, it's a problem. But if you're normally low, you don't really know, like, you'll be like, okay.
I brought it up because I've gotten it on a 120 exam before, where they say, "Hi, I'm presenting my normal blood pressure is this," and one of the answers will be, "You have to deal with this abnormally low blood pressure." You know, where if someone says like, "Oh, I always have this blood pressure,"
Yeah.
well, you're alive, so
Like I said, it depends on how low. If
Depends-
it's slightly low, it's fine.
90 over like 60, people have that like regularly.
Yeah.
That's like a thing, especially.
I think it also depends on other symptoms they're having. If they're not experiencing any other symptoms and it's normally that low, then it's fine. But if they're experiencing other symptoms that are kind of key words to be like, oh, that's a problem, then you have to think about it.
Yeah, it only matters if they say this is my normal, and then it's like that. Unless it's
Yep.
like 50 over 40.
Yeah, something that's extremely low to a dangerous percentage is a problem, no
They
matter
wouldn't-
what.
Because they wouldn't be able to speak.
Exactly. But I mean, like they were saying, I don't remember who said it, but like you have patients with COVID coming in with abnormally low blood ox levels, but they're walking and talking. Like usually if you saw somebody with those blood ox levels, they'd be being intubated and couldn't communicate, but they're walking in and talking. So they kind of reevaluated the idea of how low your blood ox is when you get intubated. Alrighty. Major risk factors: hypertension, smoking, obesity, physical inactivity, dyslipidemia, diabetes, microalbuminuria, or GFR is less than 60, old age, and family history.
I have too many points on my license. I don't.
Oh, you're not muted.
Yes. Oh,
Oh no, he did not get pulled over, right?
He probably did, and I muted him.
Oh,
Jesus.
that didn't sound so good.
Nope.
I've gotten out of some dumb shit. So.
My fiance used my low blood sugar once as an excuse as to why he got pulled over for speeding.
I have a PBA cards from like 2 different detectives from my family,
Nice.
and I had a guy who didn't care about either of them, but he specifically cared about my excuse where I'm like, I have asthma, I'm rushing home.
Wow.
Taylor, and that's what got me off. Not these two
Yeah.
executive cards.
Yep. But yeah, I experience, we believe that it's because of my illness, but I experience drops in blood sugar sometimes, like real low. And one time he got pulled over for speeding and he's like, I'm using your blood sugar as an excuse. I'm like, go for it. He was like, I'm sorry, we have to get home. She's having a low blood sugar episode. I need to get her home. And he's like, she doesn't have anything here. And I was like, no, we just came from Long Island. We have nothing. And they were like, okay, be safe. And I'm like, thank you. Medical illness, a great way to get out of a ticket.
My brother gets pulled over frequent because he works at his lab is in Jersey and he lives in Marine Park, Brooklyn.
Uh-huh.
And he drives a Tesla. So he drives just super fast. And
Uh-huh.
like they just see that they see the plates and then he shows them that he's a doctor and for some reason they give a fuck. It's so stupid. But
Yeah.
whatever. My brother drives like an idiot.
I mean,
He goes.
I got a discount on my wedding because I'm a nursing student, only because COVID.
I don't know the correlation between weddings and being a nursing student.
Well, no, it's because like it's like a give back to the community and like the first responders kind of thing. And because I work as a nursing student in the hospital for clinicals, they're like, oh, you get the discount. I was like, okay, cool. I'm not gonna lie, nursing students are gonna be reaping benefits to high holy hell after we graduate because they're increased. I'm moving to North Carolina after I graduate. They increase the salary of a nurse almost like 50% because they need nurses so badly. The signing bonuses are absolutely insane. They're like $10,000 for a signing bonus right now. Like because COVID was so terrible, they're dropping nurses because they're refusing to get shots, their COVID vaccines, so they're losing their jobs. And they're just so low on nurses to begin with that like we're gonna like get so many benefits because they're so low on nurses. Like we had the best timing for becoming nurses.
Depends on where you're at.
It does.
Florida sucks.
Oh
still.
no, never Florida. But like
Florida-
New York is gonna be great. South Carolina, North Carolina, like those places are gonna be fantastic.
California is the best.
California is the best. They pay amazing, but living there is a fucking
Also
bitch.
only allowed to have 5 patients.
Yeah, it's great. You have a 5-patient limit, you get paid amazing, but it's expensive to live there. So live out of state and travel for work. Best option. If you don't mind going cross country. Okay. Patient assessment. We have history and physical examination, retinal exams, laboratory tests, including urinalysis and blood chemistries, and we have the ECGs. Glenn, did you just get pulled over?
No, I did not. Someone wants to raise me, so I give him an excuse.
What?
Okay.
I cannot do a race and study and drive at the same time.
No. Yeah, don't do that. Alrighty.
I guess
Medical management. We got maintain blood pressure. We want less than 140/90 for anybody below 65. Anybody above 65, we accept 150 to 90/90. That's just because older patients usually have a higher blood pressure. Lifestyle modifications, weight reduction, a DASH diet, which decreases sodium intake, regular physical activity, and a reduction in alcohol consumption. Next, medical management, we have pharmacologic therapy. We decrease the peripheral resistance, which is the blood volume, and we decrease strength and rate of myocardial contractions. These meds are diuretics, beta blockers, alpha-1 blockers, combined alpha and beta blockers, vasodilators, ACE inhibitors, ARBs, calcium channel blockers, dihydropyridines, and direct renin inhibitors. So these are the drugs that are going to stop the pressure.
Somebody type HTCT, or what was it?
Hydrochlorothiazide, yeah.
Oh,
Isn't that a diuretic?
A thiazide diuretic, yeah.
Yeah,
what? How does alpha blocker work again?
alpha blocker? Oh, I don't remember. Let me see if I can find one. Beta, calcium. I don't have an alpha. We had so much high blood pressure is normal treatment for stage 1 hypertension. Hydrochlorothiazide is a stage 1.
It is
I don't know.
because severe hypertension is treated by regular diuretics. It's not treated by just one diuretic, it's treated by multiple.
Yeah.
So for just regular hypertension, yeah, it's hydrochlorothiazide is the first thing, assuming they have nothing else wrong with them that indicates the other ones.
Yeah. I mean, hydrochlorothiazide is probably the first diuretic they try as long as they don't have issues with their potassium. But they would probably also be on, like, depending on their race, either an ACE inhibitor or a calcium channel blocker.
Yeah.
I don't assume that they would just be on the diuretic. Okay, but we're gonna move on to for stage 1 hypertension. African Americans and patients under 60 years old, you get calcium channel blockers or thiazide diuretics. So if you have an African American patient with stage 1 hypertension, you would have them on the hydrochlorothiazide and also a calcium channel blocker. So that answers your question. I believe that was Emily. So yeah, thiazide would be. For non-African American patients, though, you would do an ACE1 or ARB. Because we have discovered that the way that hypertension works in the African American is not the same as non-African American. So they have to be on different medications because they work better.
So thiazide works better on African American population?
Yeah, hydrochlorothiazide, African American.
I thought it's only the calcium channel blocker, something.
It says calcium channel blocker or thiazide diuretic.
There's a specific medication. I don't remember what it is. Is it amlodipine?
Amlodipine, maybe.
Amlodipine is calcium blocker.
There's a specific
yeah.
blood pressure medication that is for African American.
Yeah, it's probably the amlodipine because that's the calcium channel blocker, is it not?
Is that not here? Whatever.
I just don't know why thiazide is specific to African American population.
No,
No.
A calcium channel blocker is nifedipine.
Nifedipine, okay. But no, thiazide is used for everybody. If thiazide is the presenting diuretic, assuming there is nothing for anybody else. I did the drug card recently too. I redid it.
Yeah. Well, the hydrochlorothiazide is kind of the go-to unless they have issues with their potassium. Then you use the spirulactol because that's potassium sparing.
Yeah, that's the reason those other diuretics exist.
Yep. Okay, so we got low doses are initiated and the medication dosage is increased gradually if blood pressure does not does not reach targeted goal. Multiple medications may be needed to control blood pressure.
What?
What?
No, I had a pen stuck to my. I use my laptop as a web because I don't have a webcam for my computer. That's obviously better than my fucking laptop. But, and I'm very lazy for not getting one. And then all the price of good webcams went up by triple. So I just never bought one. So now I have to
That's
use it.
because since COVID, everybody's a streamer now.
Yeah, and it's like everything gets stuck to like, it's like a MacBook, but like everything is like in the way. Like this thing's too big.
Gotcha. Okay, we got a question. For patients with uncomplicated hypertension and no specific indications for another medication, what is the initial medication?
There's your answer. That's what we. No.
Exactly, Emily. Thiazide diuretic.
Then why don't they give it to non-African American?
They
On that
do.
slide, because on that slide it didn't say that. It says POPs and
I did the
ACE
exact-
inhibitors.
Yeah, because we did this in previous semesters, and we always used the drug that was specific to African Americans. I don't have my cards with me, so.
Yeah, you can use hydrochlorothiazide and thiazide diuretics on both races. But when it comes to African Americans, the best course of action is the calcium channel blockers or the thiazide diuretics. Whereas when it comes to the white or Hispanic or other populations, using the ACE inhibitors or the ARBs is the best course of action in the beginning. This is just beginning. We're not saying at all. We're just saying very first stages of the type 1 hypertension. You're going to start them on a medication. When it's an African American, you do a calcium channel blocker or you do the thiazide diuretic to start with. And then white or other population, you have the ACE inhibitors or the ARBs initially. When it comes to needing to change medications or add medications because it's not working, then you can add thiazide diuretics or other diuretics to the other populations. But those are just examples of what you give them initially.
I don't know why my mic was muted. Amlodipine is what you give them. That's why it says CCB. It's amlodipine.
Amlodipine, okay.
It's like what you would give in African Americans for hypertension first.
Okay.
And then everyone else is like thiazide, but you can give them nifedipine, you can give them amlodipine and a thiazide if needed, because
Yeah.
they get really bad hypertension. And it's chronic, it's genetic.
Okay. Nursing history and assessment. We got the history and risk factors, assessing potential symptoms of target organ damage, things like angina, shortness of breath, altered speech, altered vision, nosebleeds, headaches, dizziness, balance problems, and nocturia. And then a cardiovascular assessment of apical and peripheral pulses. And then you also need to know the personal, social, and financial factors that will influence the condition or its treatment. I know some people are writing, so let me know when you're good. Okay, I'm going to move on to the next slide. Nursing diagnoses, that would be deficient knowledge regarding the relation between the treatment regimen and control of the disease process, and non-compliance with therapeutic regimen related to side effects of prescribed therapy. Collaborative problems and potential complications. We have a left ventricular hypertrophy, myocardial infarction, heart failure, transcendent ischemic attack, cerebrovascular disease, which is CVA, stroke, or brain attack. We have renal insufficiency and chronic kidney disease. And then we have retinal hemorrhage. Okay, planning and goals. We need to have understanding of the disease process and its treatment. We have participation in a self-care program, absence of complications, lower and controlling blood pressure without adverse effects or undue cost. So when it comes to hypertension, the biggest thing you need to do is educate your patient on what it is, how it can affect them, how they need to treat it, why it's important to maintain their treatment regimen, and to make sure that they do not have any issues when it comes to whether their insurance covers a medication or if it has side effects and they don't want to take it anymore. Like, they need to go to the doctor when they have those issues so a different medication can be prescribed.
Without adverse effects or undue cost.
What?
No, I'm thinking undue cost is like,
Having to spend a crap ton of money on meds that are useless to you.
undue cost.
Yep.
Adverse effects or undue cost. It's like, that's like a Latin, that's like a medieval way of saying that.
Yeah.
Undue, like, what?
The wording is god awful in half of the stuff we read. Okay. Interventions. We have support and educate the patient about the treatment regimen, reinforce and support lifestyle changes, taking medications as prescribed, and going to follow-up care.
Lifestyle changes before meds, and yeah.
What?
Lifestyle changes are before medications, and if they need
Yes. You want to try and do lifestyle changes before medications. Obviously, if you can prevent being on medications, you want to do that.
because almost everything for hypertension is preventable.
Yep. Well, that's the thing, is that hypertension isn't about treatment, it's about prevention. You want to make sure that you know about it and you control it and you monitor it so that you don't have to worry about taking all of these meds or having issues with organ damage. It's all about prevention. Evaluation and outcomes. Reports knowledge of disease management sufficient to maintain adequate tissue perfusion. Maintains blood pressure at less than 140/90, less than 150/90 for older adults, with lifestyle modifications, medications, or both. Demonstrates no symptoms of angina, palpitations, or vision changes. Has stable blood and serum creatinine levels. And has palpable peripheral pulses.
What topic are we on? Still hypertension, right?
Still hypertension. That's this entire chapter.
And why would hypertension cause the loss of peripheral pulse?
Well, because why hypertension would cause loss A loss of peripheral pulses?
Why do we have to evaluate, like assess probable peripheral pulse?
Well, because you have to make sure that that the blood flow is working properly. You need to be able to feel the pulses in the peripherals. And hypertension can lead to,
Hypertension helps it.
High blood pressure stiffens arteries.
yeah. High blood pressure leads to problems with your arteries, which
That's like-
leads to issues with the rest of your organs because it's not getting where it needs to go.
Because when blood's pumping very hard through the body, the
Yep.
arteries have to compensate and they become hard over time. That's like the main problem.
Yep.
Hypertension.
It's not so much the fact that the heart is pumping harder than it's supposed to be, it's the effects that that has on it.
Okay.
Okay, adheres to self-care program, adheres to the dietary regimen as prescribed, reduced calories, sodium, and fat intake, exercises regularly, takes medications as prescribed and reports side effects, measures blood pressure routinely, abstains from tobacco and excessive alcohol intake, and keeps follow-up appointments.
Yeah, it says keep follow-up appointments. It's like, it's the same thing as heart failure where the rehospitalization rate's really high.
Yep.
You want them to have all the information they need so they don't have to be rehospitalized, they follow up and everything. So similar.
Well, yeah. Well, when you keep your appointments, that makes sure that everything continues to be monitored properly. It also maintains their regimen usually.
Yeah, they say this for long-term conditions like chronic, like, oh, so heart failure, yeah, heart failure, hypertension.
Any chronic conditions, they're gonna say, make sure you keep your follow-up appointments.
Yeah, rehospitalization rate high. Yeah.
Mhm.
Well, not for your condition, but for like,
Well, I have to go and do my follow-ups.
you have, the follow-ups, yeah, but like, your rehospitalization rate isn't like hypertension or heart failure where they're in there and out every couple months. Well, hopefully. Assuming no complications. Okay, there you go.
I was hospitalized with pancreatitis 3 times last semester alone. I've had pancreatitis 8 times so far this year. So that's once monthly. And that doesn't include my ER visits when I didn't have pancreatitis. I'm there all the time.
You have that elevated version of that condition.
Yeah. The condition on a normal level, no, people don't have that issue. My condition, where it doesn't want to listen to any kind of restorative process, I go there all the time. I actually have a procedure scheduled though, so that's exciting.
Do you have that during the semester?
Yeah, I have to, or else I'm going to be in the hospital all the time.
What's that?
It's a ERCP. It has a long ass name. But pretty much what it is like they're gonna go endoscopically and they're gonna place stents in my bile ducts, in my pancreatic and in my common bile ducts, and they're gonna help keep my bile ducts open so that they don't close over and I don't have backup of bile, so that causes pancreatitis.
When do you have the surgery?
October 14th.
The exam's like the 30th, right?
Our test, I think so.
Yeah, okay.
I didn't check. I did the soonest possible procedure.
What's the like post-op time on that? Like,
It is technically outpatient. So I go in and you can go home the next day or that day after the procedure, like you do your recovery and then after a few hours you go home. But I've had procedures done before like this where I have usually needed to be hospitalized after. So there is a higher possibility for me to have to be hospitalized after, but I'm hoping that I can just go home.
yeah, all right. Yeah, I thought as long as it's not like a week long, then you'll be okay.
No, it's not a surgery. It's an endoscopic procedure. Will I be hurting? Yeah. Will I be like not in the best shape? Yeah, but at least I'll have the procedure to prevent the hospitalizations in the future. It's a cost benefit ratio that I'm working with here. Okay. Evaluations and outcomes, has no complications, so reports no changes in vision, exhibits no retinal damage on vision testing, maintains pulse rate and rhythm and respiratory rate within normal ranges, reports no dyspnea or edema, Maintains urine output consistent with intake, has renal function test results within normal range, demonstrates no motor, speech, or sensory deficiencies, and reports no headaches, dizziness, weakness, changes in gait, or falls. But yeah, so it's scheduled for the 14th, which is a Thursday. I'm hoping that I won't find out what time it is until like 2 days before. I'm hoping that I can get it later so that I can be in class and maybe hopefully just have to leave a little early instead of having to miss completely. But I will be missing my clinical the next day for sure. So it's going to cause absences, but hopefully it prevents future absences.
Well, after the midterm, it's kind of like home free after that. You have a lot of time to study and
Yeah.
stuff.
True.
Regardless of like the quizzes and stuff, the one quiz we have, but
Yeah. I don't know. My biggest issue is that like it's not just like physically hard on me, but it's also mentally hard on me when I get sick. Cause like going into the hospital is a bitch and a half in the first place. Having to deal with doctors just sucks. At least for my situation. Cause like the last time I went in, like when I get pain medication, a very common side effect of opioids is itchiness. So I get really itchy and I need Benadryl. But because I had a gastric bypass, I don't metabolize Benadryl orally very well at all. So I usually get it IV. This last time I went, the doctor refused to give me IV Benadryl. So I was just scratching the shit out of myself the entire time I was there. And it's also annoying to have to fight with doctors for things you normally get. And they just suck.
What type of drugs is Benadryl?
Benadryl, it's an antihistamine.
Okay. And the prototype is
diphenhydramine.
Yeah, it's
Okay.
diphenhydramine. I don't even know how to say it. Yeah. But yeah, just having to fight with doctors on a daily basis sucks. It really kills you inside. And then also when I come home, I have to have a detox off of the pain medication, which is another issue in itself because the detox off of that is like depression, anxiety, severe emotional issues. It's just like really difficult. Plus, when I'm on them, I don't remember anything. Like you have no memories. Like you get confused. You don't remember things that happen. Like it's just a pain in the ass to do school and try and do that at the same time. It's just impossible. And it just leaves me with like a defeated feeling because I feel like I'm behind because I miss so much, you know?
Yeah, they do makeups.
Oh, no, they don't. Not anymore.
Used to be able to
they
do
said they don't.
Yeah, this semester they're saying that they don't, but last semester they did. Because last semester I missed all 3 of my 115 tests. I had to retake them with Erickson.
Oh, you could
Yeah.
do like a quiz and they redistribute everything, but it's only
I don't know. They were saying this semester no makeups. So if that's an issue with me being sick during a test, I have to find out if I get fucked or not. Like the last thing I need is for them to be like no makeups. Sorry, you were hospitalized, no makeups.
following semester.
You'd really think that because they're nurses that they would be a little kinder and be like, oh, I'm so sorry, you were severely ill, we'll let you do a makeup. Like, nope, they don't care.
No, me runs like a boot camp. It's not like
She's not my goddamn teacher though. So why is she making my decisions? And Fischetti too.
on the board.
Don't even freaking get me started on Fischetti.
She's on the board, whereas
Oh, I
Eric-
know. But
Eric-
here's the thing is that Erickson is my teacher. If she says, yeah, we can schedule a makeup, I'll just rearrange the questions and answers and I can have you come on this day, then why can't I?
having 2 professors is for 120 this whole time.
Yeah.
Correct? It's always been this way.
It's just annoying. Like, I don't care if there are 2 teachers for the same class, but me is not my teacher. So why is she the one making decisions for me?
Oh.
Like, that always bothered me.
So the problem is with having 2 is that both should have their own. You should be teaching the same curriculum like a regular class, but and communicate on that. But both should have input on exams and stuff, but they don't. Only me does.
Yeah, well, I don't know. Like, I agree. They should be teaching the same curriculum, but they should not have any control over each other's classes or how they run things. Like, that's just BS.
arrived to my destination.
Oh, good. We're almost done here, guys.
Now you have to do another study group so I can listen on my way back.
Oh, yeah, no. Okay, we got medication regimen that can be difficult to remember for elderly patients. Expenses can be a challenge. Monotherapy, if appropriate, may simplify the medication regimen and make it less expensive. So just being on one drug instead of multiple. Ensure that older patients understand the regimen and can see and read instructions, open medication containers, and get prescriptions refilled. Include family and caregivers in educational program. Pretty straightforward stuff there. Okay, another question. The nurse is preparing an education plan for a patient newly diagnosed with hypertension. What should be included in the education plan? Engage in regular aerobic physical activity, such as brisk walking at least 30 minutes a day, most days of the week. Eliminate alcohol beverages from the diet. Reduce sodium intake to no more than 200 a day. Maintain a normal body weight with a BMI between 18 and 30 kilograms. What are we thinking?
Yes.
I'm trying to park, so I'm not participating.
That's okay, Bun.
Hold on. No more than 200 moles per day. It's 2 grams per day. So what the hell is a mole compared to a gram?
I have no idea.
It's not that. Normal body weight with BMI between 18 and 30.
30 is overweight.
Between is okay. It's either, I can look at the answer to this. So it's either D or it's B.
Well, what happened to A?
Nurse, this is just, the nurse is preparing an education plan.
All of the above.
What should be included in the education plan? Eliminating alcoholic beverages is huge. Maintaining a normal body weight is huge, but it's also a result. And we're trying to educate them so that they can get to that result. So it's not
And
the,
it's also a newly diagnosed hypertension.
So A,
so it's not D. D is big too. C, I don't know what 200 moles is. I know it's 2 grams. I don't know what that is.
We got someone who's saying A.
It's A or B now. But
Because B is an intervention.
Somebody said
It's
B.
not really teaching.
eliminate, no, you got to tell them to eliminate.
If you use that mentality, like of the last semester, they have to have us like distinguish like teaching or intervention or something.
Yeah.
You can't take alcohol away from them. You got to tell them not do it. Just
Okay. Well, I'm going to go to the answer now. We got A. Exercise is recommended as above. Alcoholic beverages can be assumed in moderation. Sodium should be reduced to no more than 100 a day. And the patient should maintain a normal body weight with a BMI between 18.5 and 24.9.
Fine. Within moderation, that's fine.
Yep. So we had alcohol can be consumed in moderation. It doesn't have to be removed completely. Sodium needs to be less than what the question recommended. And the patient needs to be less than the 24.9. So the 30 was too high. Make sense?
Yeah.
So that's one of those things where it's a question that all the answers make sense except for the fact that their numbers are off. So you need to know numbers.
100. No, well, boiling it down, it was between the alcohol, which increases blood pressure, and that, but it says within moderation, which I didn't remember. So, but normally, if you're not allowed to have alcohol, then it would be no alcohol. But if you
Yeah,
can,
it's limit alcohol.
yeah, then that's fine. So then you would do A every time. Because D, yeah, it's not within range, called that. And I don't know how to do mole. I don't know what that is. And the book says 2 grams. So
Yeah, I have no idea how to do moles. Okay. Hypertensive crisis. Hypertensive emergency is when blood pressure is greater than 180 over 120 and must be lowered immediately to prevent damage to target organs. A hypertensive urgency is when blood pressure is very elevated, but no evidence of immediate or progressive target organ damage. So hypertensive emergency needs to be done immediately because organ damage. Urgency is it's high, but there's no damage occurring currently. So it needs to be lowered, but it's not an emergency.
yeah, target organs. Good. Isn't the liver a target organ?
Yes.
Or the 5th one? The other one's about it, though.
Yeah. Heart, brain, kidney, eyes, liver. Liver. Yeah. Hypertensive emergency. It reduces, we need to reduce the blood pressure 20 to 25% in the first hour. You cannot drop their blood pressure from however high it is to a low normal blood pressure because it's too big of a, it's too drastic of a change. It's going to cause issues. So you reduce 20 to 25% in the first hour and then reduce to 160 over 100 over 6 hours and then gradually reduce to normal over a period of days. Exceptions are ischemic stroke and aortic dissection. Medications is IV vasodilators, so sodium nitroprusside, nicardipine, nicardipine, phenoldipan. Dude, I don't, nitroglycerin. That's the biggest one that we know. Okay, and then you need very frequent monitoring of blood pressure and cardiovascular system. Okay, hypertensive urgency. Oral agents can be administered with the goal of normalizing blood pressure within 24 to 48 hours. It's a fast-acting oral agent, beta-adrenergic blockers, angiotensin converting enzyme inhibitors, alpha-2 agonists. The patient requires close monitoring of blood pressure and cardiovascular status. And you have to assess for potential evidence of target organ damage. And this is the last slide before we have a question, and then we are done with chapter 30, guys. Sorry, 31. Yep, chapter 31. Okay, question. What is a priority nursing assessment when caring for the patient in a hypertensive crisis receiving intravenous vasodilators? Pain, in and out, vision, or family history?
Not pain, not family history. We look for hypotension. So vision and taking output. I think it's vision. But
When you're doing a hypertensive crisis and you're doing intravenous vasodilators, we need to monitor the ins and outs. You have to assess the individual's fluid volume status as recommended, because if there is a volume depletion secondary to natriusis caused by the elevated blood pressure, then volume replacement with normal saline can prevent large sudden drops in blood pressure when antihypertensive medications are administered.
so it's just extra fluid loss. Okay. Get it.
Yeah. Ins and outs are important when you're dealing with hypertension and heart in general.
But it's a biggest vasodilator you can get. So you think of hypotension immediately. And then assessing the individual volume depletion secondary to natriuresis. So it's just extra. Yeah, it's on top of that, as opposed to the vision, which is a sign of it.
Yes. Vision is a sign and symptom. It's not something that you necessarily would assess for a reaction after administering a drug.
You can assess that because if they're dizzy,
You can assess it, yes, but when you're giving a drug, especially for cardiac, one of the things that you have to monitor is ins and outs. Especially because, like you were saying, when you're giving a vasodilator, you have to worry about hypotension. And if you have hypotension, then you're not getting enough circulation going, which would lead to fluid accumulation, which means less fluid going out, which means ins and outs would be off.
Oh, it's considering that other antihypertensive medications are okay.
Yep. Okay. We have finished chapter 31, guys. We have caught up. So, any questions for what we have covered today?
Wednesday is like the big day where you can like.
Yep, Wednesday is going to be big.
People want help with that math sheet that was linked in the chat. So we could be asking about it.
Yeah.
Because that's short.
Okay. Yeah. I mean, definitely put together something for math that we can do on Wednesday. Okay, if there are no questions, I'm going to end this with another reminder. Wednesday, 4 p.m. is a study group for the quiz. I will not be recording it, so if you want to study for the quiz, you have to come to it. Bring questions that you have, because we're not covering all of the information again, because it's way too much. You're welcome, guys. Thanks for coming. But yeah, so bring questions, get ready to study for the quiz, and I will hopefully see a lot of you guys on Wednesday night.
How many ounces in a quart of water?
Ounces in a quart?
A quart. Like how much is a quart?
Well, there are 8 ounces in a cup, and there are 4 cups in a quart. So 4 times 8.
32.
32 ounces. So 1/4 of 32 is fucking 8. I'm an idiot. Okay, never mind. I get it. That's
Emily
so
just
fine.
sent a conversion sheet in our group chat.
Yeah,
Thanks,
yeah.
Pint
Emily.
is 2 cups.
No, I just didn't, that I didn't remember. I have everything, but I don't have what a quart is because I've never been asked what a quart is. And
Yeah.
the thing says, "What's a quart?" I'm like, okay.
What's a
Yep.
pint then?
Okay, stop recording.